Hello and welcome to Vasospastic angina. Our third and final type of angina. We, up until this point, have categorized angina as being chest pain, depending as to whether or not there's rest or upon exertion. And I told you at the time that when we were discussing unstable and stable angina, that we would leave vasospastic separately because it doesn't necessarily fall into the same pathogenesis of stable, unstable, and then MI. The spectrum that we had walked through there, and you want to make sure that you travel through that pathogenesis so that as you go through it, you are integrating the physio, you are looking at the disease, and then how do you want to manage your patient. With stable angina, do you remember that patient? There was chest pain upon exertion, nitroglycerin, so that you can relieve some of that pain. And so by doing so, you are decreasing the preload and decreasing the afterload and making it much easier for the heart to then function, correct? Unstable angina, my goodness, now the atherosclerotic plaque. Key point, atherosclerosis. That plaque is getting bigger. We went through the pathogenesis of that. And then remember, the cardiac enzymes were negative, black and white. Keep things simple so that at least you have a definitive answer and you're confident with your response. Now, clinically, there's always room for overlapping in that gray area, but at this point, let's just keep things very straightforward. So with vasospastic, as the name implies, formerly known as Prinzmetal, maybe you've known it as being variant, but a much more clinically relevant term would be vasospastic. That's exactly what's occurring in your coronary artery. Let's take a look. With focal coronary artery spasm, the operative word here is spasm. What's causing this? Well, we'll get to the risk factors. It's rather, let's say, mysterious. Could be, because you don't have to have an atherosclerotic plaque. How can you confirm that? Take a look at this. Angiographically, there's an absence of narrowing of the coronary artery, which means what exactly is causing this chest pain that could mimic angina? ST segment elevation, what does that even mean? Well, let's just make sure that we're clear about the different type of changes that we've seen thus far. Remember, in medicine, it's about reinforcement and repetition. And we'll keep talking about this over and over again until, well, whenever a question has been posed to you, you're able to reflexively answer, and you've come up with the right one every single time. An ST elevation, well, with anginas, remember, in stable angina at rest, there is no pain. The EKG looked normal. You induced, perhaps, in your clinic, stress either through chemical, drugs, or a treadmill test, right? Upon doing so, what did you find on your EKG? You find an ST depression. Then you had unstable angina. With unstable angina, well, you might have changes there as well, but it'd be non-STEMI, right? Maybe there's an ST depression, and the pain there occurred at rest. Now, the point is this. Cardiac enzymes were negative with angina because it's not myocardial infarction. The myocardium has not been destroyed. You're not releasing troponin I. Here as well, with vasospastic angina, has nothing to do with atherosclerosis. You usually do not find narrowing. The spasms are taking place. You might find an ST elevation, but you normally will not find cardiac enzymes. Is that clear? Now, when you hear about ST elevations, a couple things that should come to mind, and you need to make sure that you confirm your findings before you choose any type of answer. For example, if it's an ST elevation and there's no cardiac enzyme, highly unlikely that this is myocardial infarction, right? So what might it be? Was your patient taking up cocaine, smoking? Was there hypertension? Things of that nature. And if there was, that ST elevation would then diagnose your patient most likely with vasospastic angina. Is that clear? I hope so. Now, the vasospasms could be superimposed with an atherosclerotic plaque. So that you want to be careful of. So here, once again, you might find an ST elevation. With vasospasms, it's important that you go back and take a look at the history. Is your patient obese? Then at that point, you're looking at more of a type of unstable angina, perhaps, especially if the pain of the chest is occurring at rest. If your patient has a history of smoking and you find an ST elevation with your cardiac enzymes being negative, are you listening to what I'm saying? Then what is your most likely diagnosis, please? Good. Vasospastic angina. Let's continue. Now, the clinical manifestations are the following. Your patients here tend to be younger. That's key, isn't it? Whereas when we were referring to unstable angina and company, then those patients, well, if it was a male, a little bit younger than a female, but still 45 and above in a male. And if it's a female, remember that estrogen is protective, isn't it, for a female? And so therefore 55 and above, perhaps, for atherosclerosis in a female. Now, one of the hyperlipidemias that we referred to was type 2 hyperlipidemia or hyperlipoproteinemia. Do you remember type 2? What was the problem there? Good. LDL receptor deficiency. That's where the problem took place. If the LDL receptors aren't working properly, specifically in the liver, then how is the LDL ever going to be properly accepted and absorbed? It's not. You're going to start accumulating more and more LDL. Now, there could be the familial type, and you then call that what, please? Familial hypercholesterolemia. Is that clear? Now, that patient could be young, granted. All of that is dealing with atherosclerosis. And by younger, we mean to say that, well, autosomal dominant with type 2, in their 40s, that patient would be heterozygous or homozygous. What do you remember from genetics? What type of gene pattern is more dangerous? Homozygous. So that patient might only be, 18, 20. Whereas if you had heterozygous, then you're looking at a patient maybe perhaps in their 40s. But that's all atherosclerosis. Is that clear? Our topic at hand is vasospastic. And all I'm trying to do here is make sure that you have differentials in your mind before you confirm, or how do you confirm your finding is what you're truly asking yourself every single time. It occurs in atypical pattern, frequently at rest and clustered, so that's quite different. Patients here, the chest pain, very much like angina. What does that mean? Substernal chest pain may be radiating up into the jaw and to the left side and such. Take a look at the risk factors. You pay attention to this, please. Smoking, cocaine, and maybe perhaps even diabetes mellitus. But what kind here, please? What kind of patient most likely is going to then offer insulin resistance? An obese patient, when those insulin receptors aren't properly functioning. A type 2 type of diabetic mellitus. Risk factors are huge here. As you can see, really has nothing to do with atherosclerosis, vasospastic angina.